Good evening, everyone. Thank you so much for coming out tonight to learn a little bit more about precision medicine and cardiology. To introduce myself, my name is Annalise Page. I'm a licensed certified genetic counselor at the TriHealth Precision Medicine Institute, and I'll be talking a little bit more about how we apply genetic information in cardiology care. So we're going to explore what is precision medicine, understand the concept and how it plays into everyday healthcare, identify heart conditions that might have a genetic component. Heart disease is very common. How do you know what types of heart disease might be inherited from mom or dad? And then summarize for someone interested in undergoing to see if they carry a gene mutation related to a heart disease. How do they go through that process that we call genetic counseling? We'll also learn how to recognize that individuals who have a genetic mutation associated with heart disease have an elevated risk to develop heart disease over someone who does not carry that type of mutation. And then we will learn to translate the limitations around genetic testing in the direct-to-consumer realm. So those kits that you can buy on your own that's delivered to your house without the overseeing of a healthcare provider. So just to start, what is precision medicine? Well, it's come a long way in the last even 5 or 6 years, but it's tailoring healthcare to the person sitting in front of you. So taking into account not only behaviors like lifestyle habits and environment, but also a genetic makeup. So we're trying to veer away from a one-size-fits-all approach when it comes to medicine. That was the standard for a long time, and we had some individuals who did great on certain treatments and some individuals who did not respond, and we're starting to learn why that might be. So as we think about precision medicine today, we're going to focus specifically on the genetic component. So in cardiology, the goal is to identify a small number of people, relatively small, who carry a genetic mutation associated with increased risk for heart disease. And the goal is to take that knowledge and use it to deliver an appropriate medical intervention. So the goal is to decrease the overall kind of progression of disease and to find medications that will target the underlying causes of these types of genetic heart conditions. And so usually if you have a personal or family history of cardiovascular disease that looks suspicious, you might be referred to a genetic counselor. So who are we? Who are genetic counselors? A lot of times at dinner parties when I say what I do, I get a, what is that? So essentially, we're not doctors, but we are master's trained healthcare professionals that have expertise in not only medical genetics, but also psychosocial counseling. There's a lot of emotions and complicated things around learning that you have a genetic risk to develop heart disease. And I particularly specialize in cardiovascular genetics, but I have colleagues at the Precision Medicine Institute who specialize in cancer, pharmacogenomics, so how do our genes have us have certain drug interactions or we have bad side effects, prenatal genetic counselors who work with pregnant people or people who want to get pregnant, and then also there are other counselors that do things like neurology or kidney. So there are many different types of subspecialties. So we're master's educated from an accredited institution, and then we are board certified by the American Board of Genetic Counseling. And in the state of Ohio, we are also licensed by the Ohio Medical Board. So there are some states that have licensure, some that are in process, and some that do not. So before we get into the nitty-gritty of it all, going over some genetic terms that we hear snippets in articles in the news sometimes. So what is DNA? It is the molecule that carries your genetic information and develops you. Our eye color, our hair color, our height, a lot of things are, sorry about that, are determined by our DNA. So I like to think of our DNA as a book, a huge encyclopedia with thousands and thousands of pages. A gene is a basic unit of that DNA. So a gene is a sentence within that giant book. So we have thousands of genes within our DNA. And that's the basic unit of inheritance. It has a very particular job. That's what's passed from parent to child. An important thing to remember is that somehow in the kind of jargon of today's society, we say, oh, it skipped a generation. That's, when a child looks a lot like grandpa, but not a lot like dad. So that is impossible. Genes are not able to skip generations. So if whatever your genetic makeup would be is kind of what you're determining for your offspring. It can't skip from your parents to your children. A mutation is a change in DNA, so it's essentially a misspelling within the sentence that is the gene, and not all mutations are bad. So that's where it gets a little confusing. All of us in this room have thousands of mutations that just make us a little bit different. They don't actually increase risk for something like heart disease. And then autosomal dominant is just a term I might throw around, so I wanted to bring it up, but it is not related to the X or Y chromosome, so people can inherit this equally regardless of their sex chromosome makeup. And every individual, if someone has a genetic mutation to develop heart disease, all of their children, all of their siblings, and their parents will have a 50% chance to test positive for that same mutation. Sorry, my graphic isn't showing up. There it is. So genetic heart conditions, what are they? You know, we talk a lot about heart disease, heart failure. What exactly is genetic heart conditions? So one of the main types of heart conditions that can be inherited are an arrhythmia or an abnormal heartbeat. So one example of this is something called long QT syndrome. So when you have an EKG or ECG interchangeable done at a doctor's office or in a cardiology clinic, it has very specific kind of peaks and ebbs and flows here. And so the Q in green and the T in purple indicate the cycle that your heart goes from being relaxed to contracting. And it's a very specific time that the heart allows itself to do that to make sure that the rhythms are continuous and don't get out of sync. So if you have a longer version of this, then you're at increased risk to develop arrhythmias like tachycardia, so your heart beats really fast. It can also increase the risk for sudden cardiac arrest or even death if it goes untreated. In another type of heart disease that's inherited is the cardiomyopathy, literally meaning heart muscle disease. The two main types that we tend to talk about in the genetic space are hypertrophic and dilated. Hypertrophic meaning thick, so your heart muscle gets thicker than we would expect, and that can lead to issues like having an abnormal heartbeat. A lot of times you'll read about young athletes like football players. They have an echo or imaging of their heart and they're found to have hypertrophic cardiomyopathy because they're overworking it so much that it becomes thick, and then they unfortunately can't play that sport anymore because now they're at risk to develop arrhythmia. And then dilated cardiomyopathy is essentially the heart becomes very, very thin and it's not able to pump blood into the heart as well as it should, and that can lead to complications down the road. So those can be inherited. Sometimes with dilated cardiomyopathy, you might hear family members use the words like congestive heart failure, things like that. Sometimes that can be dilated cardiomyopathy. Aortic aneurysm, so the aorta is our main blood vessel that runs from our heart all the way through our abdomen. The types that tend to be hereditary, you will have an aneurysm or kind of almost a pouching form, tends to be above the diaphragm, so in the chest, sometimes called thoracic aortic aneurysm. And this can be an increased risk for this to dissect. So essentially the connective tissue that keeps our aorta the way it should be weakens over time, and then it can break and then it will dissect and you will internally bleed. Unfortunately, those tend to be fatal unless you can get immediate medical intervention. And then dyslipidemia, so when your doctor draws your lipid panel, your primary care physician, they're looking at things like your cholesterol, your triglycerides. High levels of LDL or bad cholesterol can be genetic, especially when we see levels over 190 or if we see very young heart attack in the family, usually age 40 or below. That is an increased risk to develop coronary artery disease or plaques, and that again increases that risk to have a heart attack. And the last kind of main category of genetic heart disease is autopsy negative sudden cardiac death, or in some cases unexplained cardiac arrest. So these are individuals who may have a completely clear medical history and then one day they collapse. Their heart has stopped beating completely. It's different from a heart attack. The heart just stops beating, sudden cardiac arrest. Most of the time it is unexplained. Usually, if you have autopsy negative, meaning they can't find anything wrong with your organs, they don't see any sort of coronary artery disease, that could be an indication that maybe there's an underlying cardiomyopathy or arrhythmia that increased that risk, and then you had an arrhythmic event and passed away. So why do we do genetic testing? To, first of all, clarify or confirm a diagnosis. If a cardiologist is between two types of cardiomyopathy, this could help confirm what type it is. Of course, the purpose of precision medicine, guide personalized medical management, avoiding certain triggers for people who have genetic mutations, and we'll use an example here soon. And probably one of the most reasons that people move forward with genetic testing is to identify at-risk family members. Some of us have very large families, some of us even who have small families are able to get out and communicate genetic information, and that could essentially almost save a life. If someone is told that they have a genetic risk for an arrhythmia that they never knew, now they can be watched more personally, they can be on medication, maybe have a pacemaker implanted, and it might prevent something like a sudden cardiac arrest. So let's use some examples here. So usually if someone is found to have an aortic aneurysm, when they go to see a cardiologist, they review what's the plan here, how are we going to move forward with management? And a question that is asked is, when do we intervene surgically to prevent that aneurysm from dissecting? So when are we going to go in and put a graft around the aorta to try to prevent that aneurysm from dissecting? Normally, and this is a case-by-case basis, but normally it's around when that aneurysm reaches the diameter of 5.5 centimeters. Now, if someone goes in and has a genetic counseling appointment and they decide to move forward and see if they have a genetic risk or genetic explanation for why they have this aneurysm, and they're found to carry something like an MYLK mutation, that's a gene that does carry a risk for aortic aneurysm and dissection. What they do is they follow everyone that they know who has an MYLK mutation, and they record, when did this person have a dissection? What diameter was the aorta? And this graph is showing that people with MYLK mutations have had dissection around 4.5 to 5 centimeters. So that tells the cardiologist and the cardiothoracic surgeon that we would need to intervene surgically earlier than if you hadn't had any genetic testing, and that potentially we could have missed something. There could have been an aneurysm that could have been prevented with this genetic information. So that's an example about change to treatment and surgery timing. Recommended lifestyle changes. So thinking about the arrhythmia side again, I mentioned long QT before. There are many, many types of it, and there are many different genes involved in it. So if you have a mutation in this gene KCNH2, that is a gene involved in moving potassium in and out of our heart, and that just keeps our heartbeat on schedule. So there are certain outward triggers that increase the risk for a cardiac event, meaning palpitations, fast heart rate, sudden cardiac arrest, or even sudden cardiac death. In the case of long QT syndrome, auditory stimuli is a big trigger. So a lot of times these individuals are recommended to have alarm clocks removed from their room. They're supposed to avoid going to a scary movie that might have a jump scare. So that is an example of a big life change that can happen if you have a certain mutation. In any type of long QT, you're going to be recommended to stop taking medications that prolong your QT interval. So anyone who has a completely normal heartbeat, those medications, yeah, they prolong our QT a little bit, but not enough to have an abnormal cardiac event. But if you already have a genetic risk to develop that longer QT interval, you want to eliminate anything that's going to increase that risk to make it even longer, which again increases the risk for a cardiac event. And then a lot of times when I see individuals who come in and they have a personal history of cardiomyopathy, a lot of times one of their first questions is, how will this change my treatment? And I'm very honest that most of the time it really doesn't. With the cardiomyopathy genes, usually your cardiologist is not going to change what type of medication you're on or how they follow you personally, but it really is important for the family. So for this individual in this family history, and this is an example of a pedigree, which is what genetic counselors will take when you meet with them. He was diagnosed with cardiomyopathy at 55 and now has this mutation that explains his condition in MYBPC3. Now we know his 20-year-old son, his 17-year-old son, and his 14-year-old daughter all have a 50% chance to carry that MYBPC3 mutation. And most likely that 14-year-old daughter especially is not being followed by a cardiologist, because that's typically not a recommendation for a 14-year-old. So if she does carry the genetic mutation, she's going to get annual cardiology screening, or maybe every 2 to 3 years, because we know that she's at risk. And even within families, this can present very differently. So some families might have a father with cardiomyopathy at 55, but then maybe a daughter develops it at 22. So there's still some debates in the genetics community about why that is the way that it is, but we definitely know that variability makes us want to screen earlier and more often. So been talking a lot about genetic counseling. So just to review how that process works in general, but also within the TriHealth Precision Medicine Institute. Typically a doctor, in the case, usually a cardiologist or a primary care physician or an OBGYN will refer someone to our clinic, or individuals can self-refer if they hear about us on the news or they look at our website. They can just call up our departmental line and schedule an appointment. So no genetic testing is drawn at the time that appointment is made. You come in, you meet with a counselor for about 30 minutes, and we go over everything and anything. All questions you have around, what type of genes are we going to look at based on your personal and family history? What are some psychological aspects of this? Are you feeling anxious? Is this the right thing for you and your family? How are you going to communicate this with your family if it is positive? How does this affect your job or your insurance coverage? Is this a pre-existing condition? Can you lose your health care coverage? That is illegal. There are federal laws in place to protect individuals from that type of discrimination, but there are, of course, exceptions within that law, so we make sure that you're comfortable moving forward with that. What are the possible results of genetic testing? Again, not all mutations are bad, so you're going to need someone there to interpret what those means for you and your family, and just reviewing, what type of things we're going to be looking at. And typically, if you come see a cardiovascular genetic counselor, you're not testing for cancer or Alzheimer's. You're focusing specifically on cardiovascular disease. Same as if you went to see a cancer genetic counselor, you'll be talking about cancer and doing cancer testing specifically. So using an example to illustrate this, a 40-year-old gentleman has just moved into town. He establishes with a new family doctor, and he says, I think I have high cholesterol. I definitely know my mother has high cholesterol, but I don't have any lipid records going way, way back, so we should probably draw that. And PCP said, absolutely, we are going to do that for your annual. And this might look familiar to people who have looked on my chart and saw their lipid labs. But this shows that his LDL is high. So when we talked about high cholesterol being genetic, I gave that cutoff of 190. So his is 201. So his doctor says, have you ever had genetic testing? No. Would you consider genetic counseling? So he refers, and the genetic counselor will take this big family history. So we learned from talking to this individual that he has a son and a daughter who both have had normal cholesterol so far. His two sisters do have high cholesterol. His brother does not. His mom has an LDL of 250, which is higher than his. And the medication she's on just have not been working for her. Her LDL can't get down. And then we also see that there was a maternal grandfather who died young at 60 of a heart attack, and he might have had high cholesterol. So the genetic counselor says, this looks like genetic high cholesterol. The inheritance pattern matches up. It's that autosomal dominant. And here's what we're going to order. We're going to order a 4-gene panel, and it's just going to look at genetic high cholesterol. So when it comes back, we have a positive result. So essentially what the lab does is they read through those 4 genes, again, just like reading a sentence in a book, and it shows that there is a pathogenic or harmful mutation in PCKS9. So this gene, it makes a protein that essentially helps recycle the receptors that sit on your liver that clear out that LDL or bad cholesterol. So this report is telling me that his PCKS9 is on overdrive, and it is wiping out those LDL receptors. It is behaving abnormally, and this explains why he has high cholesterol. So no matter how much he eats and exercises, eats healthy and exercises, he will always have high cholesterol because he was born with a genetic mutation. But we are able to give him a more defined risk. So because he has a mutation and his LDL is within the range of 190 to 220, we can tell him he has a 17-fold chance to develop coronary artery disease, much higher than the general population. And sometimes in the literature we learn that for individuals who might be less compliant with their statins or exercising or eating well, this information kind of motivates them to be compliant. They know they have an inherent risk that is written in their genes. But also their doctor now knows that they will respond very well to a certain class of medications. So if you remember on his family history, he said, my mom does not respond well to statins. That's probably because she has genetic high cholesterol, and you need more than one medication if you have genetic high cholesterol to get that LDL down. And so PCSK9 inhibitors are very effective, especially in individuals with genetic high cholesterol, like PCSK9. So now he has a tailored risk assessment, as well as a more responsive medication and more understanding of what he can expect. But also he goes to his family. And so for individuals who have dots inside their symbol, they tested positive. So for his 11-year-old son who reportedly had normal cholesterol, he has a risk, and he's 11. And a lot of times families ask me, well, isn't that a little young to know he's at risk for high cholesterol? But you start statins at age 8, typically, if you have genetic FH, and you are still at risk to develop coronary artery disease and cardiac events at a young age. And the brother who had normal cholesterol is positive, and one of the sisters who reportedly had high cholesterol is negative. So it shows us a more definitive map of who's at risk. And the mother, as we suspected, did test positive. So we can confirm it didn't come from dad's side of the family. So I'll finish up just by reviewing direct-to-consumer testing. So usually around Christmas time, that's when everybody sees these commercials come on. Learn about your family. Oh, I found out I had Irish ancestry. I absolutely think that learning your ancestry is fun as recreational genetic testing. Genetic counselors get concerned when these companies offer them on, learn about your family. Oh, I found out health screenings. So you order this test, and when you go to select what test you want for these types of companies, they give you, do you want ancestry only? Do you want disease risk or health information? So if we think about specifically heart or cardiovascular genetic testing offered on direct-to-consumer panels, familial hypercholesterolemia, which again, very common, 1 in 200 people, so that's why I use it a lot as an example. They test for 2 genes. There are at least 4 genes associated with FH and a couple other genes that can look like FH, so already you're missing 2 very important genes on this test. Another condition that they test for is hereditary amyloidosis or transthyretin amyloidosis, which is a rare condition that can cause cardiomyopathy as well as some neurological findings like bilateral carpal tunnel or tingling in the hands and feet. And you'll notice that I have these little descriptors here. Again, the mutations are those just little misspellings in the gene or in a sentence. So if you're looking at that LDLR gene, the direct-to-consumer test is going to look at 24 misspellings, but there are 2,000 of them that we know of. So we're missing thousands of mutations on this report. They also offer health predisposition reports to try to estimate your risk to develop atrial fibrillation, low HDL, high LDL, triglycerides, and coronary artery disease. None of that has been validated, and we don't do any of that in the clinical setting. So if direct-to-consumer testing finds something, or even if it doesn't find anything, many societies, including the National Societies of Genetic Counselors, the American College of Medical Genetics, they recommend that this be performed again in a CLIA-certified clinical laboratory that has more advanced technology and equipment. And one of the reasons for this is an article came out in 2018. I remember I was in graduate school and my supervisors, I walked in, they were very solemn, and we talked about this for weeks. This really shocked the genetics community. Basically, they looked at individuals who had undergone direct-to-consumer testing and had had a positive result. So that result came back and said, you have a high risk for cancer or connective tissue disease. So the majority of the genes they studied were related to breast and ovarian cancer. So this is not completely cardiology related. But of the individuals who had positive results, they confirmed 60% of them, but 40% of those were false positives. And a lot of these women had already gone to their physician and gotten their breasts and ovaries removed for nothing. So it's fun to see those commercials and be like, I want to test this, but it's really important to remember, especially when you're looking at the health, that this has real world devastating consequences for a lot of people. But it's not only false positives, it's false negatives. And if we think about, again, that FH condition, there was a study that came out in 2019. It looked at about 3,000 individuals, and they said to every individual in this study, okay, we're going to do your genetic test twice. We're going to run it once through a direct-to-consumer company, and again through a CLIA-certified clinical lab. And then we'll compare the two and see what we get. So they looked at two genes, LDLR and APOB, which are the ones included on the direct-to-consumer panel. The CLIA-certified lab identified 700 or so individuals, so 26% of that cohort, did carry a harmful mutation and they're genetically diagnosed with high cholesterol. Whereas for the same exact people, only 8.5% were identified as having a harmful mutation. So 2/3 of individuals who have genetic FH are going to get a negative genetic test, and it creates false reassurance. And a false negative rate of almost 70% is not acceptable. So that is another thing to keep in mind when looking at these results. So in conclusion, when you see or you're talking to your family or you have friends and you're talking about family histories, type of heart conditions where you might want to consider seeing a genetic counselor are cardiomyopathies, arrhythmias, the aortopathies or aortic aneurysm, high cholesterol. There are some other dyslipidemias like high triglycerides or low HDL that are less common, sudden cardiac arrest or sudden cardiac death, and transthyretin amyloidosis. And consider going to a genetic counselor. We're trained and experts in interpreting these results and making sure that you get the best care and that your family members are getting the best information. And so precision medicine is used to determine risk, like we saw for the gentleman with familial hypercholesterolemia, make lifestyle recommendations, such as individuals with long QT syndrome and removing those medications that might put them at higher risk, and make management recommendations, like we saw with the aortopathies and when to intervene surgically. And then finally, take caution when using direct-to-consumer genetic testing, and if you have any questions at all, seek genetic counseling. And that's everything. Any questions? Yeah.
How is the aneurysm diagnosed?
It is typically diagnosed on a CT scan, or sometimes they can see it on echocardiogram. So typically someone has a family history, and that's how they find it, or they're having symptoms that might indicate that they have aortic aneurysm.
What would be the symptoms?
Shortness of breath, or I will defer the rest to a cardiologist.
Why would you even test?
Why would you? That's a good question. A lot of times we don't find it until there's been an aortic dissection. So usually that's how family members get alerted, because a relative has had a dissection and they've been airlifted to a hospital and had emergency surgery. And it's not kind of like a standard screening that a doctor would order. That's not the recommendation.
So I found out 3 years ago I have a pretty high calcium score. But I've never heard anything about genetic testing other than I did do 23andMe. And so, I guess, as I think about it, I have a son who's 28. So if I have it, because I probably had it I've been taking Lipitor for 20 years. So it's now been ratcheted up because of this calcium score that I have. And so I'm just wondering, I've never heard a doctor ever talk about genetic testing, though. And, other than, asking me, do I have it in my family? Which both my parents have had cardiac events. They're still both living, but they both had they both had stents. And
Mm.
my mom's had cardio bypass
Mm.
surgery. So I'm just curious, like, is it because it's not mainstream yet, or?
Basically, yes. So there are many publications from different societies that do recommend genetic testing for various conditions. Some of them are a little bit outdated, especially for aortic aneurysm, but there seems to be kind of a disconnect in, in the past it used to be, oh, you have a family history, you're at risk, and that was enough to guide your management. So I think a lot of people, especially in the case of high cholesterol, and this is a fair argument where they say, I can diagnose this clinically. I can look at someone's LDL level and know that they have familial hypercholesterolemia. What does genetic testing add? Now, that has been studied in recent years, and a lot of literature says, well, the traditional kind of diagnosis criteria for high cholesterol is kind of outdated. We're learning that a lot of individuals with FH don't have an as obvious what we call phenotype or outward clinical appearance. So doing genetic testing can almost double the rate of diagnosis of familial hypercholesterolemia. Also, it again is important for risk stratification. So it's just about education about how it actually can change management. But a lot of times, individuals have been educated throughout their schooling and training that it can be based purely on a clinical diagnosis.
Yeah, because I wouldn't have found it. I mean, I found it
Yeah.
because my buddy and I said, maybe we should get scanned. That's how we can also find those aneurysms.
Mhm.
So I had a scan, and that's how they found the calcium. My calcium, and I was not expecting it. Yeah. Other than
Yeah.
I had not high cholesterol, it was 250, and I brought it down through Lipitor or whatever.
Yeah.
Now, maybe you didn't go to the genetic testing phase necessarily because it was controllable with a statin, right? Versus the multi-drug panel you were talking about that might take. But I'm just, as I'm sitting there saying, I would expect the physician at some point to say, hey, you've got this. You have children, you should probably have them screened, right?
Yeah.
Because you're right. I mean, 23andMe, it'll just tell you have an affinity to something or something like that. But it's not really saying. And it didn't even bring up I didn't have any of the markers for heart disease, really. So it's just, I was just curious. Is that just doctors? It's not really part of their process, I guess.
Yeah, I think also in medical training, it just tends to fall by the wayside. And so that's kind of why we exist as genetic counselors, is to also work side by side with the clinicians and educate on the importance of genetic testing. And unfortunately, there just aren't a lot of genetic counselors, and there are a lot of physicians. So
because I go to TriHealth.
that is the goal. Right now, I'm the sole cardiovascular GC. Hopefully, we'll have more help.